Okay, good morning, everyone, and thank you very much, Madam, for the opportunity. I'll be discussing about the pharmacological management of COPD. Uh, During my presentation, I will briefly discuss about the drugs used in the treatment of stable COPD, and then management pathways of stable COPD, and then finally I'll discuss some things about the management of acute exacerbations of COPD, then the drug management. So first, what are the goals of treatment of stable COPD? So here we treat to reduce symptoms and reduce future risks. Here mainly the one of the main targets of the treatment is to relieve symptoms and to improve exercise tolerance of the patients and improve the overall general health of the patient. And then we target to prevent the disease progression and prevent and treat the exacerbations of COPD, and then finally to reduce the mortality. So let's see what each of these drugs can do to achieve these targets. So in the management of stable COPD, drugs are categorized mainly into two categories: the bronchodilators and anti-inflammatory agents. Uh, Bronchodilators, as you all know, starts with beta 2 agonists. So we all know that it acts on airway smooth muscle beta 2 adrenergic receptors and reduces the smooth muscle tone and increase expiratory airflow. And what are the proven clinical effects of beta 2 agonists in COPD? So as needed SABA short-acting beta 2 agonists have shown to increase FEV1 and have shown to improve symptoms in patients with COPD. In addition, other than LABA, that is formoterol and salmeterol, have shown to increase FEV1, lung volumes, dyspnea, general health status, exacerbation rates, and number of hospitalizations. So here you can see we can achieve a lot of treatment targets by using LABA in patients with in COPD. And indicator, this is once daily LABA. Is it more user friendly? Again, improve breathlessness, health status, and exacerbation rates. But importantly, long-acting beta agonists, formoterol, salmeterol, and indicator, none of those have any effect on mortality or reduction in rate of declining lung functions. Next group of bronchodilators are antimuscarinic agents. Again, very important group of drugs in COPD. They act by attaching to M3 muscarinic receptors in airway smooth muscles. Short-acting muscarinic antagonists, ipratropium and oxytropium, they also block neuronal M2 receptors, which very rarely can cause vagal induced bronchoconstrictions, but like it's almost negligible. And long-acting muscarinic antagonists, that is in tiotropium, they specifically bind with M3, this airway smooth muscle receptors, but dissociate fastly from M2 receptors of nerves. So what are the proven clinical effects? So ipratropium is better than SABA in COPD, and LAMA, that is tiotropium, has shown to improve symptoms, health status, and effectiveness of pulmonary rehabilitation programs, and they have shown to reduce exacerbations and related hospitalizations in patients with COPD. So the tiotropium has greater effects on exacerbation rates rather than LABA, long-acting beta agonists. So combination LABA-LAMA therapy. This combination therapy is superior to either of the monotherapy in improving FEV1, improving symptoms and quality of life, and reducing exacerbations. Some methylxanthines, this theophylline is very commonly used in the clinical practice, but the guidelines say not to use. So mechanism of action, those are non-selective phosphodiesterase inhibitors. By doing that, they create a bronchodilation, and in addition, they also have an anti-inflammatory action. In numerous clinical studies, they have shown to improve FEV1 and improve symptoms, but still it is like in guidelines, these are not recommended mainly because of their adverse effect profile. Uh, the the most serious adverse effect is atrial and ventricular tachyarrhythmias, which can be fatal sometimes. And other than that, they can have minor side effects, but common like nausea and heartburn. They have a lot of drug interactions, especially with antibiotics such as erythromycin and ciprofloxacin, but not azithromycin. And they have a very narrow therapeutic range. Because of that, we should be careful if you are using this drug, especially in older people, as we don't have any facilities to monitor the drug levels. So what are the guideline recommendations on theophylline? Goal 2022, theophylline is not recommended unless other long-term treatment bronchodilators are unavailable or unaffordable. That means like the patients can't afford or they can't use inhalers, then there's a place for this theophylline. NICE 2019 guideline again has a similar kind of a recommendation. And another, the other recent available guideline was Canadian Thoracic Society guideline, again 2019. They also don't recommend the use of theophylline in management of stable COPD. Uh, then the next group of drugs, anti-inflammatory agents. First one is inhaled corticosteroids. Inhaled corticosteroids alone, that is meclamitzone or any corticosteroid without combination with LABA, they have no effect on mortality or FEV1. But ICS plus LABA combination therapy, it has shown to reduce the rate of exacerbations and improve lung functions compared to either the drugs alone. And triple therapy, LABA-LAMA ICS, this again has shown to improve lung function, symptoms, and reduce rate of exacerbations compared to LABA-LABA combination or LABA-ICS combination or LAMA monotherapy. But if you use regular inhaled corticosteroids in patients with COPD, they are at high risk of developing pneumonia. There are specific groups in which we can use this inhaled corticosteroids. I will discuss it later. ICS, inhaled corticosteroids, has very little or no effect when the peripheral blood eosinophil count is less than 100. And it shows a greatest benefit when the blood eosinophil count is more than 300. So this is what this basically summarize in which patients we can use inhaled corticosteroids in patients with COPD. ICS use is strongly supported in patients with prior history of hospitalization and 2 or more moderate exacerbations in the previous year. That is because mainly the inhaled corticosteroids have shown to reduce the exacerbation rate rather than relieving symptoms. Because if the patients are having more exacerbations, so then there's a place for this ICS, provided these exacerbations are not due to pneumonia. So if these are due to pneumonia, that is against the use of ICS. And in addition, if the blood eosinophil count is more than 300, and if the patient has a past history or concomitant history of asthma, then again there's a place for inhaled corticosteroids. You can consider ICS use if the patient is having one moderate exacerbation of COPD during past 1 year, or if the blood eosinophil count is in between 100 to 300. It is not recommended if the patient has repeated pneumonias and if the blood eosinophil count is less than 100, and if the patient has previous history of mycobacterial infection. And oral glucocorticoids, long-term oral steroids are not recommended. They have no benefit. Then phosphodiesterase 4 inhibitors, roflumilast. Mechanism of action is breakdown of intracellular CAMP and reduce inflammation. It has shown to, especially in patients with chronic bronchitis, this chronic bronchitis is defined as presence of productive cough for 3 months for 2 consecutive years. So if the patient has that type of clinical history and plus severe COPD and history of exacerbations, in these type of patients, this proflomelas has shown to improve lung functions and reduce further exacerbations. Antibiotics, again, this antibiotics does not mean like the antibiotics we are using in acute exacerbations. This is long-term antibiotic use have shown to reduce exacerbations in infection-prone patients. So, which are the drugs which has evidence? Azithromycin, the dose is 250 milligram daily or 500 milligram 3 times per week for 1 year, or erythromycin 250 milligram twice per day for 1 year. So to get a benefit, you need to use these doses for this duration. But there's the usage of these antibiotics has higher risk of bacterial resistance, QT prolongation, and hearing impairment. And it has shown to be have lesser benefits in current smokers. Mucolytic agents such as NAC and oral carbamazepine, again, regular treatment has shown to reduce exacerbation in selected populations. I will discuss this later. So then I will go into the discussion of the management of stable COPD. This is mainly based on the Goal 2022 guidelines. Again, the same thing I have discussed previously. So I think our madam has discussed this slide previously. So initial treatment depends on the group of COPD. So we categorize the patients with COPD into two groups, A, B, C, D. Here on the x-axis we have the symptoms of the patients defined like classified by MMRC dyspnea scale, 0 to 1 here and more than 2 here. And the number of exacerbation on this y-axis, 0 to 1 exacerbations during past year here, and more than 2 exacerbations or at least 1 exacerbation requiring hospital admissions here. And so these are the drugs which we should use in the initial treatment. You should use as the initial treatment in the management of stable COPD. Group A, any type of bronchodilator can be used, but especially LABA or LAMA is preferred. But even short-acting beta agonists can be used here according to the guideline. Group B, either LABA or LAMA, long-acting bronchodilator beta agonist, or long-acting muscarinic antagonist, one of these drugs. In Group C, it has to be started with LAMA. Group D, again we can start with LAMA or LABA-LAMA combination or ICS-LABA combination depending on the individual patient's characteristics. So we'll discuss this more later. So Group A, all patients should be offered a bronchodilator, either short or long-acting one. Group B, initial therapy should consist of a long-acting single bronchodilator, either LABA or LAMA. Choice between LABA and LAMA depend on the patient perception of symptom relief. If the patient is not responding to LAMA, you can try LABA likewise. And for patients with severe breathlessness, there is even if the patient is in Group A, if the patient has severe shortness of breathing, you can try with 2 bronchodilators as initial therapy. Group C, initial therapy always should be started with LAMA. In Group D, again, generally the treatment is started with LAMA. That is mainly the available one for us is tiotropium. And LABA-LAMA combination therapy is recommended in patients who have severe symptoms rather than exacerbations. Like the patient, they have higher MMRC dyspnea scale or higher this CAT score. If the CAT score is more than 20, this is a COPD assessment tool. So then the LABA-LAMA combination can be started. If the patients are having recurrent exacerbations, then initial therapy with LABA ICS can be considered. So the management cycle, so we start the treatment and then we relieve the patient with symptoms and whether the patient has had any exacerbations, and then again we assess for the patient for the inhaler technique and adherence to the treatment, and all the other non-pharmacological approaches should be re-evaluated, the ones that our madam has discussed, and then we have to readjust the treatment, either escalate, de-escalate, or switching of inhaler devices dry powders, from dry powders to MDIs, like or the other way. This is how the follow-up management plan should go. So on follow-up visits, when we reassess, if the patient is stable with the current treatment, we can continue the current management plan. But if the patient is if the patient's COPD is not under control, then we should see whether the patient is having worsening of breathlessness, or whether the patient is having recurrent exacerbations. Depending on that, the management, further management differs. So if the patient is having both dyspnea and exacerbations, then we should treat as for the exacerbations. So if the patient is having, if the patient's COPD is not under control because of the dyspnea, and if the patient is on a single long-acting bronchodilator, then we should add the second agent. If the patient is on LAMA, we should add LAMA to that treatment. And if there is no improvement, we should step down to monotherapy. And there is no improvement with adding second line agent, we can always consider switching inhaler device from MDI to DPI, or the other way around. Or if the patient is on formoterol, we can try with salmeterol or something. So for patients with persistent breathlessness or exercise limitation on LABA ICS combination, then we can add LAMA to escalate to the triple therapy. If the patient is on LABA-LAMA combination as initial treatment, then we can consider adding ICS if the patient is having indication for ICS, like higher eosinophil count. If the patient's COPD is not under control because of exacerbations, and if the patient is on bronchodilator monotherapy, it can escalate to LABA ICS or LABA-LAMA combination. This LABA ICS is preferred in patients with, as I have previously discussed, who have past history of asthma, one exacerbation per year with more than 300 eosinophils, and two moderate exacerbations, or one exacerbation requiring hospital admission with more than 100 eosinophils. And if the patient is on LABA-LAMA combination and still the patient is getting exacerbations, then we can escalate to triple therapy. And if the patient is getting recurrent exacerbations, and if the blood eosinophil count is less than 100, then there is place for this roflumilast and azithromycin. And if the patient develop exacerbations while on LABA-LAMA ICS, again, like LABA ICS, we can always escalate to triple therapy. And if the patient develop exacerbations while on this triple therapy, we can add roflumilast in patients with FEV1 less than 50% predicted, and this has a history of chronic bronchitis. And we can add macrolide in non-smokers, as it has shown to be less beneficial in current smokers. And while on triple therapy, still patient is getting exacerbations, we have to reconsider the usage of ICS, because these exacerbations can be due to recurrent infections. So therefore, we might try to stop this ICS as well. Okay, then the last part, the pharmacological management of acute exacerbations of COPD. So acute exacerbation is defined as acute worsening of respiratory symptoms that result in additional therapy. Any acute worsening of symptoms requiring additional therapy is defined as acute exacerbation. So the goal of treatment of exacerbation of COPD is to minimize negative impact of current exacerbation and to prevent the further exacerbations. So unfortunately, there is no clear flow chart to describe the exacerbation management. So I'll discuss the drugs which are used in the management of acute exacerbations. First thing is always oxygen. We all should remember oxygen is a drug, and we should prescribe oxygen. We should prescribe the route of oxygen, the what device through which we can give, and the FiO2 and the duration we should give the oxygen, and then what are the things we need to monitor, and we should give a saturation target as well. So in COPD, controlled oxygen to achieve a saturation of 88 to 92% is preferably via a Venturi device uh, is recommended, because if they are, you all know, if they go into higher oxygenation, if they are on a hypoxic drive, they can go into worsening of type 2 respiratory failure. And then continuous saturation monitoring with frequent ABG monitoring for oxygenation and pH and CO2 levels is recommended. Then the second treatment is bronchodilators, inhaled beta 2 agonists with or without short-acting anticholinergics, that is salbutamol plus or minus ipratropium can be used. These drugs can be used whereas MDI or MDI with a spacer or nebulization depending on the patient's situation. Here the air-driven nebulization is recommended as compared to oxygen-driven nebulization in the management of asthma, because of this risk of over oxygenation in the patient. And again, here the intermittent nebulization is recommended compared to the continuous nebulization. Then the use of glucocorticoids. The guideline recommend a dose of 40 milligram of prednisolone per day for 5 days. Large doses and prolonged courses are associated with pneumonia and increased mortality. There's no significant difference between oral prednisolone and parenteral IV hydrocortisone or parenteral steroids. And in certain patients, nebulized budesonide alone may be beneficial. Antibiotics in the acute exacerbations. So antibiotics, in which patients we should use antibiotics? It is recommended to use antibiotics in patients with these three cardinal symptoms: increase in dyspnea, increase in sputum sputum volume, and increase in sputum purulence. The patient has these three symptoms. Without any blood investigations or chest x-rays, we can prescribe antibiotics according to the guideline. Or if the patient has two of these cardinal symptoms, and one of these should be this increased purulence of sputum, then again we can prescribe antibiotics. And if the patient require mechanical ventilation, always we have to prescribe antibiotics. This inflammatory markers guided antibiotic use is not recommended in this guideline. PCT guided antibiotic is not recommended. Rather than that, they recommend this clinical judgment and starting antibiotics. This recommendation has made mainly because there are some studies have shown in HDU and ICU settings, if you give antibiotics according to PCT and stop antibiotics according to that, it has shown to increase the mortality. So because of that, they have not made any recommendation on this. Normal duration of antibiotic therapy has to be 5 to 7 days. So which antibiotics we should give? Ideally, it should depend on the local drug resistance. Their usual recommendation is IV co-amoxicillin with a macrolide to cover atypical infections. And in all the patients, we should send a sputum culture before starting antibiotics. So again, here this aminophylline, one of the very commonly used drugs in the management of acute exacerbations of COPD in our settings. But Gold 2022 guideline, they are not recommending this mainly because of the increased side effect profile. But 2019 NICE guideline, they say if there is inadequate response to nebulized bronchodilators, you can use IV aminophylline. But if you are using that, you have to monitor the serum levels within 24 hours of starting treatment. Then the other adjunct treatments such as fluid management and diuretics if the patient has copulmonary edema, and anticoagulation prophylaxis if the patient is immobilized. One study has shown about 6% of patients with acute exacerbations of COPD have pulmonary embolism. Because of that, if the patient is immobilized, we should always prescribe anticoagulation prophylaxis, and all the other comorbidities associated with COPD has to be treated. So these are my references. Main two references were the Gold 2022 report and NICE 2019 NICE guideline on management of COPD. Okay, thank you very much. And then I would like to invite Dr. Channe Langasinghe to discuss the nutrition management of COPD.